Welcome to the deep dive. Today we're really zeroing in on Alpha-1 Antitrypsin Deficiency.
A1AT deficiency.
You sent over some brilliant, really detailed notes, and I think our mission today is to kind of pull out the essentials, right? Make it stick.
Exactly, the high yield stuff.
Yep.
So A1AT deficiency, at its heart, it's genetic. The body just doesn't make enough Alpha-1 antitrypsin protein.
Okay, and that protein comes from the liver.
Made in the liver, yeah. But its main job is protecting the lungs. It's a vital protector.
Right, a protector, like a bodyguard for the lungs. So what's it guarding against?
It's guarding against certain enzymes, particularly one called neutrophilelastase. A1AT keeps it in check.
Ah, neutrophilelastase. So if you're deficient in the bodyguard protein?
Then that enzyme can damage the lung tissue, which, well, significantly bumps up the risk for COPD.
Especially in younger people or non-smokers, which is a key flag, isn't it?
Absolutely. And it's not just the lungs. It can hit the liver, too. Think cirrhosis, potentially.
Okay, let's unpack the cause then. You said genetic.
Yeah, it boils down to mutations in a specific gene, SERPINA1.
SERPINA1, and that's on chromosome 14.
Chromosome 14, that's the one. And there are, honestly, tons of variations, like over 100 different alleles for this gene.
100. But we probably only need to focus on a few key ones for, practical purposes.
Exactly. The main ones to remember are M, S, and Z. Think of M as normal.
M for normal, okay. And S and Z.
S and Z are the variants that lead to lower protein levels. Z is generally the most severe.
So how you inherit these matters. If you get 2 copies of S or Z, like SS or ZZ.
That's when you have the lowest A1AT levels,
Mm-hmm.
and consequently the highest risk of disease. That's the homozygous state.
Homozygous SS or ZZ, highest risk. What about having just one, like MS or MZ, heterozygous?
They also have reduced levels, yeah. Maybe not as drastically low as ZZ, but still lower than normal, and that carries an increased risk too.
Right. So diving into the etiology, the cause is that SERPINA1 mutation messing with protein production in the liver.
Precisely. And the inheritance pattern is usually called autosomal recessive, though some describe it as co-dominant because even heterozygotes show some effect, like those lower protein levels.
Okay, autosomal recessive or codominant, chromosome 14, got it. And those alleles again, M, S, Z, based on how fast the protein moves in a test. Electrophoretic mobility.
Yeah, that's where the names originally came from. M is medium normal, S is slow, Z is very slow. So PMM, that's the genotype, is normal.
PM normal, then PMZ is heterozygous.
Yep, 1M, 1Z,
Yep.
and PSC are homozygous.
Now that PMZ state, the notes mention some discussion around the emphysema risk there.
Yes, that's a good point. The evidence is a bit mixed, or maybe nuanced is a better word. For someone with PiMZ who doesn't smoke, the actual risk of developing emphysema seems quite low.
Low risk if you don't smoke, but there's still carriers.
Exactly. They can still pass that Z allele on to their children. And, smoking changes the game entirely for anyone with lower A1AT levels.
Makes sense. And just to put numbers on it, PSS gives you about, 50% of normal A1AT?
Around 50%, yeah. Whereas PZ, that's way down, maybe only 10% of normal levels.
Wow, only 10%. That really highlights the severity for PZ individuals.
It really does. It explains the much higher disease risk.
Okay, so risk factors. Number 1 is clearly family history, right? If it runs in the family.
That's your primary risk factor, absolutely.
Yeah.
Inheriting those S or Z alleles.
But it's not just genetics. What else plays a role?
Environment is huge here. Smoking is the big one. It dramatically accelerates lung damage in people with the deficiency.
The single most important environmental factor.
By far. Also, exposure to dust, fumes, occupational pollutants. Those can also worsen things. They're secondary factors, but still significant.
So genetics loads the gun, but environment, especially smoking, pulls the trigger.
That's a very good way to put it. The pathophysiology, how it actually works, is that lack of functional AET protein.
The missing bodyguard.
Right. So neutrophilelastase isn't inhibited properly. It starts to break down elastin, a key component of lung tissue.
Leading to lung damage. Emphysema, COPD.
Exactly. Destruction of the air sacs.
Okay, so when someone presents with COPD-like symptoms, especially younger or non-smokers, we need to think A1AT deficiency. But what else is on the differential diagnosis list?
Good question. You definitely consider standard smoking-related COPD, of course. Asthma is often in the mix.
Asthma, okay.
Bronchiectasis, too, which can sometimes coexist or be a feature of A1AT deficiency itself.
Mm-hmm.
And then there are other much rarer genetic lung or liver conditions.
So keep a broad perspective initially. Now, How common is this actually, the epidemiology?
It's surprisingly common, particularly among people of Caucasian descent. It's one of the most frequent inherited disorders in that population.
Really? What kind of numbers are we talking?
Well, the severe PiZ genotype affects maybe 0.1% globally, roughly 1 in 1,000 based on some estimates, maybe less frequent depending on population. PiZ is more common, perhaps around 0.7%.
In the UK.
Estimates vary, but often cited as somewhere between 1 in 2,000 and 1 in 5,000 people having the severe deficiency, the PiZ type.
That's still quite a few people. But you mentioned it's underdiagnosed.
Hugely underdiagnosed. Symptoms can be variable, they overlap a lot with regular COPD, and it often takes years to get the right diagnosis.
And I saw a statistic that, up to 5% of all COPD diagnoses might actually be undiagnosed A1AT deficiency?
That's a figure often quoted, yes.
Mm-hmm.
It really underscores the need for awareness and testing, especially in COPD patients who don't fit the typical smoker profile or have a family history.
Wow. Okay, so clinical presentation. What should make you suspect it? What does it look like?
Common symptoms are shortness of breath, especially on exertion, persistent wheezing, a chronic cough, maybe producing sputum and getting frequent chest infections.
Sounds a lot like typical COPD. Any specific clues for A1AT deficiency?
Yes, in the lungs, the pattern of emphysema is often described as panisonar. It affects the entire acinus, the functional unit of the lung air sacs, and tends to be worse in the lower lobes of the lungs.
Panisonar, lower lobe predominant. That's a key difference from the central-lobular upper lobe pattern often seen in smoking-related emphysema.
Exactly, that's a classic radiological clue. And then there's the liver involvement.
Right, the liver. What happens there?
In adults, it can lead to cirrhosis and even hepatocellular carcinoma, liver cancer. In infants, it can sometimes present as cholestasis or neonatal jaundice.
So lung and liver. And the age of onset for lung symptoms, you said younger.
Typically, lung disease starts to show up in the 30s or 40s. But crucially, if the person smokes, it can start much earlier, even in their 20s or 30s.
Much earlier in smokers. And the lung issues can manifest as emphysema, but also bronchiectasis or even lung cancer, potentially even in non-smokers.
That's right. For the liver, it might be picked up incidentally with abnormal liver function tests, LFTs, or present later with jaundice, hepatitis signs, or the complications of cirrhosis. Important to note, though, not everyone with a gene defect gets significant liver disease.
Okay, so variability there too. How do we confirm the diagnosis then? Investigations.
The first step is a simple blood test to measure the level of Alpha-1 antitrypsin protein, if that's low.
Then you follow up?
Then you follow up, usually with genetic testing. That can be phenotyping, which looks at the protein type, or genotyping, which looks directly at the SERPINA1 gene for the specific MSZ mutations.
Okay, blood AA2 level, then genetic testing. What about assessing the impact? Lungs, liver?
For the lungs, pulmonary function tests, or PFTs, especially spirometry, are crucial. They'll typically show an obstructive pattern like in COPD.
Measuring airflow limitation.
Exactly. Imaging helps too. A chest X-ray might show signs, but a high-resolution CT scan and HRCT gives a much better picture of the emphysema pattern and extent.
HRCT for detailed lung view, and for the liver.
Liver function tests, LFTs, are standard. Ultrasound or other liver imaging might be used. And sometimes, if things are unclear or to stage disease, a liver biopsy might be necessary.
And testing family members.
Absolutely critical. Since it's genetic, identifying one person means siblings, children, potentially other relatives should be considered for testing. Early detection is key.
Makes total sense. Okay, we found it. Management. What can be done?
The overarching goals are symptom control and, really importantly, preventing further lung damage.
And top of the list for prevention must be
Smoking cessation. Absolutely non-negotiable. It's the single most effective thing someone with A1AT deficiency can do to protect their lungs.
stop smoking. Paramount. What else?
Avoiding passive smoke and occupational dust fumes is also important. Moderating alcohol intake is generally advised, partly thinking about potential liver effects.
Lifestyle measures, medications.
Standard COPD treatments help manage symptoms. Bronchodilators, both short and long-acting. Sometimes inhaled corticosteroids if there's an asthmatic component or frequent exacerbations.
So similar to managing regular COPD symptomatically.
Yes. Plus, preventative vaccinations are really important. The pneumococcal vaccine and annual flu jabs to reduce the risk of serious chest infections.
Good point. And what about specific A1AT treatment, augmentation therapy?
Yes, augmentation therapy. This involves intravenous infusions of A1AT protein derived from human plasma. The idea is to replace the missing protein and protect the lungs from further elastase damage.
Does it work? Is it widely used?
It's shown some benefit in slowing the progression of emphysema in selected patients, but it's complex, expensive, and requires lifelong infusions. Its availability and funding vary globally.
Okay. And managing the established lung disease.
It's largely the same playbook as for non-A1AT COPD. Pulmonary rehabilitation, oxygen therapy if needed, prompt treatment of infections. For very severe cases, lung volume reduction surgery or even lung transplantation could be considered.
And the liver side.
For the liver, it's about monitoring liver function regularly. If cirrhosis develops, managing that and its complications as you would for any other cause. And screening for hepatocellular carcinoma is important, especially in males with cirrhosis.
Screening for liver cancer. And if the liver fails badly.
Liver transplantation is the definitive treatment for end-stage A1AT-related liver disease. And interestingly, a liver transplant actually cures the A1AT deficiency itself because the new liver produces normal AAT protein.
Oh, that's fascinating. The new liver fixes the protein problem. Are there newer therapies on the horizon?
There's ongoing research into things like recombinant A1AT, not from plasma, and even gene therapy approaches to try and correct the underlying genetic defect, but those are still largely experimental.
Right. And just a note for our UK listeners, you mentioned NICE guidelines.
Yes, it's worth noting that currently, NICE in the UK generally does not recommend routine augmentation therapy, mainly based on cost-effectiveness assessments and uncertainty about long-term clinical impact for many patients, so access is limited here.
Okay, important context. So prognosis, what's the overall outlook?
It's highly variable. It really depends on the genotype, PiZ being worse than PiZ, for example, how low the AAT levels are, whether lung or liver disease develops, how severe it is, and crucially, whether the person smokes.
Smoking again, the big modifier.
Absolutely. Non-smokers with A1AT deficiency generally do much, much better than smokers. Early diagnosis, ideally through screening before major symptoms develop, also tends to lead to a better prognosis because interventions like smoking cessation can start sooner.
And severe airflow obstruction on PFTs is a bad sign.
Yes, the degree of lung function impairment is a major predictor of outcome.
Okay. And finally, the potential complications we need to watch out for.
The main ones are the progression of lung disease, worsening emphysema, chronic bronchitis leading to respiratory failure. Development of liver cirrhosis and its complications, including portal hypertension and ascites.
And liver cancer.
And hepatocellular carcinoma, yes. Plus, an increased risk of other lung issues, like bronchiectasis developing.
Right. So to wrap up the key high-yield takeaways, A1AT deficiency is genetic, SERPINE1 gene, chromosome 14, impacts lungs via protease inhibitor deficiency, leading to emphysema risk.
Especially panacenar lower lobe predominance, often in younger non-smokers, and potential liver disease too.
Diagnosis involves AAT levels and genetic testing. Management hinges on smoking cessation above all else.
Plus standard COPD care, vaccinations, monitoring liver health, and considering augmentation therapy in specific cases, though access varies. Prognosis is heavily influenced by smoking and disease severity.
Got it. Complex, but the core mechanisms and risks seem clear.
Exactly. And for anyone wanting to really nail this down for exams or further learning, do check out pastthemsra.com and also freemsra.com. Lots of good resources there.
Excellent. And just to leave you all with something to think about, given how often A1AT deficiency seems to be missed, what more could realistically be done in healthcare systems to boost awareness and maybe catch this condition earlier? Something to ponder. Thanks for joining us for this deep dive.